Hello everyone, welcome to our channel Microbe Academy. Today we are going to learn about the malaria parasite, it is Plasmodium. In this video we will learn about the malaria parasites, its life cycle, mode of transmission, disease, pathogenesis and the diagnosis of the disease. Okay, now let's learn about the malaria. Malaria is a vector-borne parasitic disease caused by protozoan parasites that belongs to the genus Plasmodium. The parasites infect the human liver cell and red blood cells transmitted by the female Anopheles mosquito, and it remains one of the most important parasitic disease worldwide, particularly in the tropical and subtropical region. Okay, now moving to the history of the malarial parasite. The name malaria was given in the 18th century in Italy, where the mal means bad and aria means the ear, where the people thought it was caused by the fall emission from the marshy soil. The specific agent of malaria was discovered in red blood cell of patients in 1880 by the Alphonse Laveran, who is a French army surgeon in Algeria, and later on in 1886, Golgi in Italy described the Golgi cycles where the sexual development of the parasites in RBCs were discovered. And the three different species of malaria parasites infecting the human are were described in Italy between the 1886 to 1890, and among them the vivax, malariae, and falciparum were described during the 1886 to 1890, and the fourth species, that is Plasmodium ovale, was identified only in the 1922. The mode of transmission of the disease was established during the 1897 when Ronald Ross identified the developing stage of a malaria parasite in the mosquitoes, and both Ronald Ross and Laveran won the Nobel Prize for their discoveries in the malaria. More than 150 species of Plasmodium exist, but the five species infect the human, that is Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, Plasmodium ovale, and Plasmodium knowleski. We will discuss about each parasites in coming videos, and among these five parasites, the Plasmodium falciparum is the most severe and deadly malaria that dominates the African continent, and the Plasmodium vivax most widespread and cause relapse due to the liver stages and prevalent in tropical and subtropical countries. Talking about the epidemiology, the incidence of disease is more in poor population in rural areas and also in the urban areas having the sanitary condition. An epidemic can develop when there is change in environmental, economic, and social conditions such as migrations and heavy rains following the droughts. The relative prevalence of among the four species of the malaria, it varies in different geographical regions. The Plasmodium vivax is the most widely distributed, being most common in the Asia, North Africa, and Central and South America. Similarly, the Plasmodium falciparum is the predominant species in Africa, Papua New Guinea, and Haiti, and is rapidly spreading in Southeast Asia and India. The Plasmodium malariae is present in most places but is rare except in Africa, and the Plasmodium ovale is virtually confined to the West Africa, where it ranks the second after the Plasmodium falciparum. Okay, now let's learn how the disease is transmitted. The transmission occurs through the specific biological or mechanical routes that allow the parasite to enter the bloodstream of a healthy individual. And the major modes of transmission are via the vector transmission, where through the bite of infected female Anopheles mosquitoes. Only the female Anopheles mosquitoes can transmit the malaria because they require the blood for egg development, via the blood transfusion and contaminated needles from the infected donor. Sharing the contaminated needles or syringes, especially among the intravenous drug users. Accidental needle-stick injuries in healthcare setting. Organ transplantation from an infected donor. and congenital transmission from mothers to the fetus, where the malaria can also be transmitted from an infected pregnant woman to her fetus, and this is known as a congenital malaria. Okay, now talking about the taxonomic classification, Plasmodium is an obligate intracellular protozoan parasite and classified under the kingdom Protista, phylum Epicomplexa, class Econoidesida, order Hemosporida, and family Plasmodidae and genus Plasmodium. And as I already mentioned, the Plasmodium genus Plasmodium has more than 150 species. Among them, 4 species can cause the malaria in human. Do you know how the phylum name Epicomplexa literally comes from? Okay, the phylum name Epicomplexa literally comes from apex means tip plus complex means structure, referring directly to its characteristics organelle complex. The member of Epicomplexa possess an apical complex or specialized subcellular structure located at the apical tip of the parasite, and it is used for penetrating and invading the host cell. So, consisting of a apical complex is the key characteristics of the phylum Epicomplexa. Talking about the habitat, parasite has a two host life cycle, that is one is human host and a mosquito host. Human host act as a intermediate host where the parasite stays occur in liver cell carrying out exoerythrocytic schizogony, and in a red blood cell carrying erythrocytic schizogony, and this erythrocytic schizogony is responsible for the cause of the symptoms of a malaria. And mosquito act as a definitive host, and the species involve the female Anopheles mosquito, where the parasite completes its sexual reproductions in the definitive host. Now let's learn about the morphology of Plasmodium. The Plasmodium does not have a single shape. Instead, it appears in different morphological stages during its life cycle. Parasite exhibits sporozoite, trophozoite, seizoid, merozoite, and gametocytic stages during its life cycle. Each Plasmodium species has their key characteristics of these morphological stages, which we will discuss in the coming videos. Here we will learn the general morphological structures of the parasite that shows during its life cycle. First of all, let us discuss about the sporozoite. Sporozoites are the infective stage of the parasite which cause the infection to the human. It is slender and elongated, measuring approximately 1 to 7 micrometer in diameter and present in the mosquito salivary gland. Sporozoites has pointed ends with central nucleus and pellicle for the movement. Similarly, trophozoites are the feeding stage present in the RBC and appears as a ring form in their early stage, and cytoplasm surrounds a central vacuum, and the mature trophozoites become amoeboid and show the pigment granules for the hemoglobin digestion. Similarly, seasoned is the multiplicative stage where the mature trophozoite that undergoes the multiple nuclear divisions and produces the merozoites that occur on the liver and RBC. And the merozoites of the parasites are oval or slightly elongated. They are small invasive cells that infect the new RBC, having a size approximately 1 to 2 micrometer. And apical complex present in the merozoites helps in the invasion of the new RBC. And similarly, the gametocytes are the infective stage for the mosquitoes, which is present in the human blood, and two types of the gametocytes are present, that is microgametocytes, which is a male gametocytes, and its cytoplasm is lighter and nucleus is large and diffused, and Another is macrogametocyte, which is a female gametocyte with a denser cytoplasm and nucleus is compact. And these stages can be observed in the Giemsa stain of the blood smear. Okay, now let's learn about the life cycle of Plasmodium. The parasite has a digenic life cycle involving the two hosts, that is, human as an intermediate host, where the parasite completes its asexual cycle known as a schizogony, and the mosquitoes act as a definitive host, where parasite completes its sexual cycle, sporogony. Okay, now let's discuss in detail about the life cycle of Plasmodium. As I already mentioned, the parasite has a digenic life cycle involving the two hosts, namely human as an intermediate host and the mosquito as an definitive host. The whole life cycle of the parasite can be divided into the two stages: human stages, which is known as a human liver stages, and a mosquito stages. Here I will discuss the two stages in a separate and subdividing the each stages. In a human liver stages, parasite completes the erythrocytic cycle, secondary exoerythrocytic cycle, and gametogony. Furthermore, the parasite completes a sporogonic cycle in a mosquito stage. Now let's discuss about the human stages of the parasite. The sporozoites are the infective form of parasites present in the salivary gland of the mosquitoes. The female Anopheles mosquito injects the sporozoites during the blood feeding. During the act of biting, the proboscis of the mosquitoes presses the skin and saliva containing the sporozoites are injected directly into the blood. After an infected female Anopheles mosquito bite, the sporozoites now enter the bloodstream of the human host and start the liver stage. Within about the 1 hour, the most of the sporozoites leave the bloodstream and invade the liver parenchymal cell. The sporozoites, which are elongated, spindle-shaped bodies, now become the rounded inside the liver cells and undergo a process of asexual multiplication where sporozoites undergoes multiple nuclear division followed by cytoplasmic division and develop into the hepatic seasons. The size of the hepatic seasons varies depending on the species, having approximately 24 to 60 micrometer in diameter. Each season contains about the 2000 to 30,000 of merozoites, and the primary exoerythrocytic schizogony occur only once in the liver. After the completion of the liver stage, the infected liver cell ruptures and releases the thousands of the merozoites into the bloodstream. These merozoites then invade the red blood cell, initiating the erythrocytic stage of malaria infection. The duration of this liver stage is different among the different species of the Plasmodium, where Plasmodium falciparum has a duration of about 6 days. Similarly, Plasmodium vivax has a duration of about 8 days. Plasmodium ovale has a 9 days, and Plasmodium malariae follows a 13 to 16 days of the liver stage. Plasmodium vivax and Plasmodium ovale, some of the sporozoites in liver cell become the dormant hypnozoites instead of multiplying immediately, and these hypnozoites can reactivate after a weeks, months, or years to form a secondary exoerythrocytic seasons, releasing the merozoites that infect the red blood cell and can cause the relapse of the malaria. Now, the merozoites liberated enter the blood streams and invade the new RBC, thereby starting the erythrocytic cycle or a blood stage of the parasites. Inside the RBC, merozoites multiply asexually and passes through a stages of trophozoite, season, and merozoites. The immature trophozoites become a mature and the season formation occur. Rupture of the season release the numerous merozoites which then infect the fresh RBC. This cycle repeats every 48 hours, giving the tertian malaria, or every 72 hours in the quatrain malaria. And the blood stage parasites are responsible for the clinical manifestation of the disease. Now, the release merozoites. Every release merozoites of the parasites does not differentiate into the male gametocytes and female gametocytes, but some of the parasites differentiated into the male and female gametocytes, thereby starting the gametogony, where the male gametocytes known as macrogametocytes and female microgametocytes are developed and start circulating in the blood. The host carrying the gametocytes are carrier. The mature gametocytes of Plasmodium vivax, Plasmodium malariae, Plasmodium ovale are round in their shape, but the Plasmodium falciparum has elongated or a crescent shaped gametocytes, and these are taken up by the mosquitoes during the bite, thereby starting the sporogonic cycle in the female Anopheles mosquito. After the uh, mosquito takes a blood meal. After the mosquito takes a blood meal, the ingested gametocytes starts a sporogonic cycle where the ingested gametocytes matured into male and female gametocytes and developed into the gametes. Fertilization occurs, developing a zygote. The zygote develops into the motile and elongated okinete. The okinete penetrates the meat coat wall of mosquitoes and develop into the oocyst. Oocysts grow, rupture, and release the thousands of sporozoites. Sporozoites migrate to the salivary gland of the mosquitoes, and the mosquitoes become infective. An inoculation of the sporozoites into the new human host during the mosquito bite completes the life cycle of the malaria parasite. Now let's discuss about the pathogenesis of the malarial parasite. The pathogenesis results mainly from the destruction of RBC and immunoresponse towards them. The major mechanism involved the RBC destructions, where the parasite multiplication lead to the lysis of RBC, resulting the anemia, and the release of the toxic substances. So during the RBC ruptures, such as parasite pigment hemozoin and parasite antigens, cause the stimulation of inflammatory responses and sequestration of the infected RBC, especially in Plasmodium falciparum, cause the infected RBC to adhere to the capillary endothelium and leads to the microvascular obstructions, and also leads to the and also causes the parasitic multiplication, also causes the several organ damage such as cerebral malaria, cause the brain damage, renal failure, and hepatomegaly and splenomegaly. Now, moving to the clinical feature of malaria, the incubation period in human after getting bitten by an infected mosquito is usually 10 to 18 days, along with 2 weeks on an average, but the incubation periods differ among the several species of the Plasmodium, having the 12 days for Plasmodium falciparum, 13 to 17 days for Vivax and Ovale, and 28 to 30 days for the Malaria. The primary symptoms of malaria include high fever and sweating, fatigue, unconsciousness, convulsion, and muscle spasms, breathing complications, dark or bloody urine, jaundice usually characterized by yellowing eyes or a skin, and abnormal bleeding. The classic febrile paroxysms consist of three distinct stages, that is, cold stage, hot stage, and sweating stage. During the cold stage, patients may feel intense cold with chill and rigors along with a lassitude, headache, and nausea. And this stage lasts for 15 minutes to 1 hour. And during the hot stage, the patients may feel the intensely hot and the temperature may rises towards the 41 degrees Celsius or higher, and the headache persists but the nausea commonly diminished. And this stage remains for up to 2 to 6 hours, And during the sweating stage, there is profuse sweating followed the hot stage, and the temperature comes down to the normal and the skin is cool and moist. The paroxysms usually begins in the early afternoon and lasts for up to 8 to 12 hours, and the periodicity is approximately 48 hours in tertian malaria and 72 hours in quadrant malaria. Usually, the tertian malaria is caused by the Plasmodium vivax, falciparum, and ovale, whereas the Plasmodium malaria is responsible for the quadrant malaria. After the few paroxysms cycle, the anemia of microcytic or normocytic hypochromic type develop due to the direct RBC lysis and the autoimmune lysis of a coated infected and uninfected RBC. There is decrease in incorporations of the iron into the hemoglobin and decrease the RBC production from the bone marrow, and increasing the fragility of the RBC leading towards the anemia. Plasmodium vivax and ovale can infect only the reticulocytes, so the parasitemia is limited around the 2 to 5% of the available RBC, whereas the Plasmodium malaria can only invade the primarily to the older RBC, so the number of the infected cell is somehow limited. However, Plasmodium falciparum can invade the all ages of the RBC, so the proportion of the infected cell may exceed to the 50%. Due to the heavy parasitemia, the complication of falciparum malaria can lead to the cerebral malaria, algid malaria, septicemic malaria, black water fever, pulmonary edema, metabolic acidosis and shock, and severe anemia, hypoglycemia, and acute renal failure. In some cases, the malarial symptoms may be mild for a people, especially those who have already been infected by the parasite beforehand. However, for some specific population groups, the onset of the malaria can be especially fatal. This includes the infant, children under the 5 year of age, pregnant women, travelers, and HIV/AIDS patients. When left undiagnosed and untreated, this can be quickly turned into the fatal and may cause the kidney failure, seizures, mental confusion, coma, and death of an individual. Okay, now let's learn how the disease is diagnosed. A laboratory diagnosis is essential for confirmation of malaria infection and starting of the treatment. The blood is the choice of the specimen, and the blood is collected by finger pricking or from the ear lobule before the treatment start. The parasites are more abundant in the peripheral blood late in a febrile paroxysms, particularly a few hours after the high fever. And all asexual erythrocytic stage as well as gametocytes can be seen in the peripheral smear of Plasmodium vivax, malaria, and ovale. But in case of the Plasmodium falciparum, only the ring form and crescent-shaped gametocytes can be seen because the trophozoites and seizoid stage of the falciparum are usually confined to the internal organ and appear in the peripheral blood only in a severe pernicious malaria. So now let's discuss how the disease can be diagnosed. And as I explained, blood is the choice of a specimen. And first of all, the microscopic examination is the gold standard for the diagnosis of the malaria. It involves the demonstrations of malaria parasite in blood in a thick blood smear, which is studied for the screening of the presence of malarial parasites. It is more sensitive, and the thin blood smear is used for the identification of the species and confirm the malarial species. Both the thick and thin smear can be used mm, stain by using the Giemsa stain. And similarly, the several rapid diagnostic tests can be used where the microscopic facilities are not available, usually in the health post or remote areas where the it detects the parasite antigen such as HRP2 antigen. It is a histidine rich protein which is water-soluble protein produced by the trophozoites and young gametocytes of the Plasmodium falciparum. Similarly, LDH antigen, it is a lactate dehydrogenase antigen produced by the asexual and sexual stage of the parasites of the all four species. Similarly, the molecular methods such as PCR method and real-time PCR method can be used for the diagnosis. Usually, the PCR or a molecular method is used for the species, specific species identification and for the several epidemiological studies. And the quantitative Buffy code test can be used. It is a fluorescent microscopic technique that uses a capillary tube coated with a actinium orange fluorescent dye where the blood is centrifuged at a high speed that separates the blood component into the three layers, that is plasma, buffy coat, and the red blood cell. The malarial parasites concentrate near the buffy coat, and under a fluorescent microscope parasites appear as a bright green fluorescent bodies. Okay, for the treatment of the malaria infection, there are several treatment guidelines, and the treatment depends on the species of Plasmodium and severity of the disease. The treatment of Plasmodium vivax involves the chloroquine and primaquine, and for the Plasmodium falciparum, ACT for 3 days, and for the mixed infections are treated similar to the falciparum malaria with the ACT plus primaquine. And for severe malaria, require the parenteral treatment, usually injectable artesunate, followed by the oral therapy or stabilization. And since October 2021, WHO has recommended a broad use of the RTS AS01 malaria vaccine among the children living in the region with a moderate to high falciparum malaria transmissions, and this vaccine has been shown to significantly reduce the malaria and deadly severe malaria among the young children. And similarly, in October 2023, WHO recommended a second safe and effective malaria vaccine of R21 matrix M, and vaccines are now being rolled out in a routine childhood immunization program across the Africa, and malaria vaccines in Africa are expected to save tens of thousands of young lives every year. And the highest impact will be achieved, however, when the vaccines are introduced alongside a mix of the other WHO recommended malaria interventions, such as bed nets and bed rest and chemoprophylaxis. And for the prevention and control of the disease, the key strategies include the early diagnosis and prompt treatment, which will the testing and timely treatment will reduce the complications and prevent the transmission of the disease. And another strategy is vector control using the insecticide treated nets and indoor residual sprayings. It reduces the mosquito populations and prevents the bite. And similarly, the surveillance and case reporting is also essential for the control measures where the early detections and reporting helps for the monitoring the trends and guide the response efforts. And the community awareness and health educations, it also empowers the communities with the knowledge of promotes which empowers the communities with knowledge and promotes the preventive behaviors. So an integrated approach combining the effective treatment, vaccination, vector control, surveillance, and community participation is essential to reduce the malaria burden and to save the lives. Thank you for watching. If you found this video useful, please don't forget to like, comment, share, and subscribe the YouTube channel. And have any queries, please let me know on the comment section.